miles an hour, but your windshield is completely blacked out.
Terrifying.
Right. The only way you can steer or even know if you're about to veer off the road or blow the engine is by staring at this wildly complicated dashboard. Just dials, warning lights, pressure gauges, all of that.
It's a great analogy, really, because that paints a perfectly accurate picture of the reality doctors face when dealing with certain, invisible internal crises.
Because you can't just see the threat.
Exactly. You can't see it with the naked eye. The patient might actually look perfectly fine sitting there on the exam table, but underneath, there's this storm brewing.
Right.
And the physician has to rely entirely on their instruments to navigate it.
And if one of those dials is off by just a fraction, the whole engine could seize up. That's really the tension we're looking at today. We are stepping into the high-stakes, highly precise world of pulmonary hypertension, or PH.
Which is a deceptively simple name, honestly.
Yeah, right.
Yeah.
Because specifically, we're looking at how doctors predict, measure, and manage the risk of this disease.
Yeah, pulmonary hypertension sounds like just regular high blood pressure, but it's actually a devastating mechanical failure.
It was high blood pressure, but exclusively in the lungs, right?
Right. The arteries in the lungs narrow and they stiffen up. So this creates a massive bottleneck. And that forces the right side of the heart to pump incredibly hard just to push blood through.
And over time, that strain just leads to right-sided heart failure.
Exactly. The engine essentially blows out.
Wow. So to understand how specialists manage this crazy balancing act, we're pulling from a really fascinating source today. We've got a set of high-yield medical review notes authored by Dr. Asifullah.
Yeah, and these notes are incredible because they synthesize the massive, really dense 2025 to 2026 AHA, ESC, and ERS guidelines.
It's basically the ultimate clinical cheat sheet.
It really is. It shows exactly how top-tier specialists approach this condition. They condense hundreds of pages of global cardiology guidelines into, actionable, life-saving math.
Because the goal isn't just lowering a number on a chart.
No, the goal is preventing that right ventricle from giving out entirely.
Right. Which means we aren't just here to recite a list of medical facts for you today.
Mm-hmm.
Our mission is to decode this precise, numbers-driven system that doctors use to make these rapid-fire decisions and monitor a very, very slippery condition.
It's a highly dynamic situation.
Yeah. Okay, let's unpack this. Before we get into the heavy artillery of the actual treatments, we really need to understand the guiding medical philosophy here. Like, how do doctors even begin to measure the threat level of a disease locked deep inside the chest cavity?
Well, what's fascinating is that the entire approach is grounded in one blunt, overarching mantra. It's right at the top of these review notes.
And that is...
low risk equals long life.
Low risk equals long life. Simple.
Simple but critical. That is the true north for any doctor treating PH. The strategy isn't just about, making the patient feel a little better today. It's a highly aggressive 3-part timeline.
The main objective being to get them safe and keep them there.
Right. First, you want the patient categorized as low risk at the exact moment of diagnosis.
Okay.
Second, you absolutely must maintain that low risk status during every single follow-up.
And the third part.
Third, if the patient slips into the intermediate or high risk categories, you do not sit back and watch. You rapidly escalate therapy.
Because the longer a patient spends outside of that green zone, the faster their heart muscle just deteriorates.
Exactly. Every day counts.
It sounds like a really intense game of aggressive maintenance. But measuring risk here seems tricky. If you're listening to this, you might be wondering, well, why doesn't a doctor just slap a standard blood pressure cuff on their arm and check the numbers?
Because an arm cuff measures systemic blood pressure. That's the pressure in the system, serving your muscles and organs.
Right.
But the lungs operate on a completely different circuit. The pulmonary circuit is locked away behind the ribs. You can't reach it with an arm cuff.
So how do they get the data on that hidden system?
They use a really comprehensive risk assessment mnemonic. It's called the 4S and 4H model.
I love a good mnemonic.
Right.
Let's break down the 4 S's first. They stand for symptoms, 6-minute walk distance, syncope, and stress biomarkers.
Right.
If we go back to our car dashboard analogy, this is the driver's side of the dashboard. These are the things the patient actually experiences, right? The warning lights popping up right in their face.
Exactly. So the first S is symptoms, which doctors actually quantify using the WHO functional class.
And that's a scale from 1 to 4, right?
Yep. It measures how much regular physical activity is limited by shortness of breath. Class 1 means no limitations.
And class 4?
Class 4 means the patient is gasping for air even while just resting in a chair.
Oh, wow. Okay, then we have the second S, which is the 6-minute walk distance, or 6 MWD. And this is almost beautifully simple. Literally, how far can the patient walk down a flat hospital hallway in 6 minutes?
Yep, just a walking test.
It just seems wild to me that with all our advanced medical tech, just having someone walk back and forth is still considered a gold standard data point.
It seems basic, but it remains the gold standard because it is a real-world global stress test. You aren't just testing the heart.
What else are you testing?
You're testing the lungs, the blood vessels, the muscles, and how they all coordinate under physical demand.
Oh, that makes sense.
Right. If the heart can't increase its output to match the muscle's need for oxygen, the patient simply has to stop walking.
Which brings us to a pretty terrifying limitation.
Yeah.
The third S, syncope. This is just the medical term for fainting.
Yes.
So if the lungs are so bottlenecked that the right heart cannot push enough blood through to the left heart, the brain basically gets starved of oxygen, right?
Exactly. The moment you exert yourself, you just pass out.
That's the ultimate system override.
It really is. And the final S takes us down to the chemical level. Stress biomarkers.
These are blood tests, right?
Yes, specifically looking for hormones like BNP or NT-proBNP.
Let me jump in on BNP for a second because the mechanism here is just crucial to understand. BNP is a hormone that the heart ventricles release when they are being stretched too far.
Right.
The right ventricle is normally used to pumping against very low pressure, like the lungs are usually soft and spongy. But when pulmonary hypertension turns the lungs stiff, that right ventricle has to push incredibly hard.
The muscle physically stretches out?
Yeah, and as it stretches, it literally dumps this biomarker into the blood. It's essentially the physical engine block groaning under the strain.
That's a perfect way to put it. And adding to that, the notes point out that doctors will also check troponin levels.
Troponin, that's different from BNP.
Very different. While BNP indicates the muscle is stretching, troponin indicates the heart muscle cells are actually dying. Yeah. If troponin is in the blood, you have myocardial injury. And that points to a vastly worse prognosis.
Okay, so we have the 4 S's. Those are the outward signs of failure. But eventually, the mechanic has to open the hood. How do doctors actually look inside the right side of the heart to get the objective data?
Well, if we connect this to the bigger picture, that's exactly where the 4 H's come in. These are your under-the-hood metrics.
Right.
Hemodynamics, heart imaging, hemodynamic congestion, and hemodynamic output.
Okay, heart imaging is probably the easiest one to grasp. That's using an echocardiogram, which is just an ultrasound of the heart, or a cardiac MRI.
Right.
But the notes explicitly state that a cardiac MRI is the absolute best tool for measuring the size and function of the right ventricle. Why is an MRI so superior to a standard ultrasound in this case?
It's because the right ventricle has a very bizarre asymmetric shape.
How so?
Well, unlike the left ventricle, which is shaped like a neat, thick-walled bullet, the right ventricle wraps around the heart almost like a crescent moon.
Oh, interesting.
Plus, it's tucked up right behind the breastbone. So standard 2D ultrasounds really struggle to capture its full volume accurately.
But an MRI can.
Yeah, a cardiac MRI provides a perfect 3D model. It shows exactly how dilated or deformed that crescent shape has become.
That makes perfect sense. But to get the remaining H metrics, so hemodynamics, congestion, and output imaging isn't enough, right?
Yeah.
Doctors have to actually go inside the plumbing.
They do. They perform a right heart catheterization.
And what does that actually involve?
It involves threading a thin, flexible tube through a vein in the neck or the groin and pushing it down into the right atrium, through the right ventricle, and wedging it directly into the pulmonary artery.
Oh, wow. That sounds incredibly intense.
It is invasive, but it allows them to measure hemodynamic congestion, specifically the right atrial pressure, or RAP.
So we're talking about plumbing back up here.
Exactly. And they also measure hemodynamic output through something called the cardiac index.
Right, the cardiac index. That's a really vital concept. It isn't just how much blood the heart pumps, is it?
No, it's how much blood the heart pumps relative to the patient's body surface area.
Right, because a massive linebacker needs a lot more blood flow than, say, a petite gymnast.
Exactly. The cardiac index normalizes that output, so doctors have a standardized metric.
Okay, so the doctor has gathered this massive pile of data. They've checked the 4 S's from the outside. They've threaded a catheter to check the 4 H's on the inside.
Mm-hmm.
How do they possibly weigh like a good walking score against the bad internal pressure reading? How do they actually score the patient?
This brings us to the 3-strata model. Think of it as a triage traffic light used at the exact moment of initial diagnosis.
Okay, green, yellow, red.
Exactly. Green for low risk, yellow for intermediate risk, and red for high risk.
The contrast between green and red is pretty stark. To get the green light, the low risk category, the patient is barely symptomatic. That's WHO functional class I or 2, right?
Correct.
They've never fainted. They can walk more than 440 meters in 6 minutes.
Mm-hmm.
And those invasive numbers from the catheter are very healthy.
Let's translate what those healthy numbers mean physiologically. Their right atrial pressure, or RAP, is under 8 millimeters of mercury.
Which means
blood is returning to the heart smoothly without backing up into the liver or the legs. Their cardiac index is over 2.5, meaning the body's organs are getting plenty of flow.
Okay.
And their mixed venous oxygen saturation, or SVO2, is greater than 65%.
Actually, explain SVO2 really quickly, because that is a super interesting metric.
Sure. SVO2 measures the oxygen level of the blood returning to the heart after it has circulated through the whole body.
Right.
If the heart isn't pumping enough blood, the body's tissues panic. They strip every single molecule of oxygen they can out of that slow-moving blood.
Oh, wow.
So a healthy 65% means the organs are well fed, but if that number drops, the body is literally starving.
Which is exactly what we see when we look at the red light, the high-risk category.
Right.
This is a system in total collapse. The patient is in functional class 4, completely out of breath at rest. They are fainting repeatedly. They can walk less than 165 meters.
Yeah, and internally, the hemodynamics are just terrifying. The fluid backup is severe with a right atrial pressure over 14.
So blood is just pooling in their abdomen and lower body.
Yes.
Yeah.
And the cardiac index has dropped below 2.0. To put that in perspective, a cardiac index under 2.0 means the heart is pumping so little blood that the kidneys, the liver, and the brain are literally starting to suffocate.
And that's when the tissues start stripping oxygen desperately.
Exactly, which drops that SVO2 below 60%.
You know, the notes highlight something really crucial here. The right heart catheterization variables, the RAP, the cardiac index, and the SVO2. These are the absolute strongest invasive prognostic variables.
They are.
They're the ultimate truth tellers.
Yeah.
Like a patient might have a good day and walk a bit further, but those internal pressure numbers strip away all subjectivity.
You cannot fake the mechanical reality of a failing pump. The numbers dictate the survival probability, period.
Okay, here's where it gets really interesting. We talked about green and we talked about red, but I'm looking at the criteria for the yellow light, the intermediate category.
Yeah.
Wait, hold on. This category is dangerously broad. The walking distance criteria for intermediate risk is anywhere from 165 meters to 440 meters.
Mm-hmm.
A patient walking 166 meters is treated the exact same way as someone walking 439 meters. That can't be right. One is practically bedridden, and the other is taking a brisk stroll.
You've zeroed in on the exact clinical dilemma that forced global guidelines to evolve. The yellow category, as originally designed, is an illusion.
Yeah.
If you treat the person walking 166 meters the exact same way you treat the person walking 439 meters, you are going to massively undertreat the sicker patient, and you'll lose the window to save their right ventricle.
So if the yellow zone is just too broad and dangerous to rely on, what on earth do doctors do when the patient comes back for their follow-up visits?
They completely abandon the three-part traffic light.
Really?
Yeah, the three-strata model is only used at the initial diagnosis to get a baseline. For all follow-up care, the ESC and ERS guidelines mandate a shift to a four-strata follow-up model.
Oh.
They take that massive, murky intermediate group and they slice it right in half.
Creating two highly specific subcategories, intermediate low and intermediate high.
Exactly. It's entirely about defining the degree of physiological strain. In the intermediate low group, the patient is stable. You see mild symptoms, maybe only a slight elevation in that BNP stress biomarker, and mild right ventricle dysfunction on the MRI.
But the intermediate high group paints a totally different picture, doesn't it?
Oh, completely. In intermediate high, the patient has slipped into functional class 3. They struggle to do simple chores. Their right ventricle is visibly struggling on the imaging, their BNT is spiking because the muscle is stretching, and their walking distance has noticeably shrunk.
So they aren't in total failure yet, but they are standing on the edge of the cliff looking down at the high-risk category.
That's exactly where they are.
The real so what's of this entire follow-up model is that this split dictates immediate clinical action. The notes make it incredibly clear. If a patient is graded as intermediate low, the doctor focuses on optimizing their current oral medications, maybe tweaking a dose. Right. But if the patient falls into intermediate high, that is an immediate trigger for treatment escalation. You don't just tweak the pills.
Yes.
You bring out bigger weapons to pull them back from the edge.
And this is exactly why the follow-up timeline is so rigorous, because pulmonary hypertension is so dynamic. Stable patients must have all of these major variables reassessed every 3 to 6 months.
Every 3 to 6 months, bringing someone in to walk the hallway, draw blood, and do ultrasounds that frequently, I mean, it speaks volumes about how fast the right ventricle can decompensate.
It's an incredibly fragile system.
Yeah.
And that schedule actually accelerates if the patient shows any signs of clinical worsening. The window for intervention is brutally narrow.
Which really leads to a crucial question. If a patient is being monitored every few months, what happens when the dashboard numbers suddenly plummet between visits? How do doctors recognize a true, immediate emergency?
Well, the notes provide another powerful mnemonic for identifying these critical high-risk red flags. It's called SOCK-RV.
SHACKRV.
Yeah, and if a patient hits these markers, they bypass standard local care. It requires urgent referral to a specialized PH center and an immediate, massive escalation of therapy.
Let's run through SHOCRV and decode the physiological panic behind each letter.
Sure.
So S is for recurrent syncope. That's the brain repeatedly losing blood flow.
Right. H is hypotension. This means their systemic blood pressure is actually crashing because the right heart is failing so badly it can't push enough blood over to the left heart to supply the body.
Wow, okay. O stands for output low. That's the cardiac index dropping below 2.0, where organs begin suffocating.
Yep. C is congestion. The right atrial pressure climbing over 14, causing fluid to pool in the liver and legs.
And K is killer BNP, meaning the biomarker is markedly elevated, screaming that the right ventricle is stretching to its absolute tearing point.
Exactly. R is for right ventricle failure, which is now visibly obvious on an echo or an MRI. And V stands for very poor exercise tolerance, meaning they can't even walk 165 meters.
When those SHOCK-RV alarms are blaring, the treatment strategy shifts entirely from maintenance to salvage. Doctors basically match the intensity of the intervention directly to the risk strata.
They have to.
Think of this treatment escalation like an escalating security response.
Okay, I like that.
If a patient is low risk, it's like a minor noise complaint. You keep an eye on it, maintain their baseline oral therapy, and maybe send a patrol car to drive by every few months.
Right.
If they're intermediate low, you send an officer to knock on the door, you optimize their oral combination therapy, maybe adding a second daily pill.
But crossing the threshold into intermediate high changes the game entirely. Doctors escalate to triple therapy. And crucially, this is where they consider adding parenteral prostacyclin in appropriate patients.
Parenteral meaning it's not a pill,
Right.
It's injected or infused.
Yes.
So if a patient is intermediate high, or worse, if those SHE-RV alarms go off and they hit high risk, we aren't just knocking on the door anymore. We are calling in the SWAT team.
You really are. The notes mandate that high risk requires urgent combination therapy, IV or subcutaneous prostacyclins, ICU support if they are decompensating, and immediate evaluation for a lung transplant.
Wow.
Oral medications are completely bypassed at that point.
Why are 5E prostacyclins considered the SWAT team of pulmonary hypertension exactly?
Because prostacyclins are incredibly powerful vasodilators, they chemically mimic natural substances in the body to forcefully relax the smooth muscle inside those narrowed pulmonary arteries.
So they literally force the bottleneck open.
Exactly. But delivering it intravenously requires a permanent central line inserted directly into the chest, connected to a pump the patient must carry 24/7.
Oh my goodness.
And the medication has a half-life of just minutes. If that pump stops, the pulmonary pressure rebounds violently, which can be fatal. It is a massive life-altering burden on the patient.
You definitely don't deploy that kind of heavy machinery for a minor noise complaint. But when the right ventricle is actively failing, it sounds like the most potent direct weapon doctors have to rapidly drop the pressure in the lungs and save the heart muscle.
It is. And the entire system is basically built to delay the need for that pump as long as humanly possible.
So what does this all mean? When we zoom out and look at this entire framework, the 4S's, the 4H's, the traffic lights, the split yellow zone, the SHOCKRV alarms, what is the core takeaway for someone trying to really grasp this disease?
Dr. Asifullah distills this massive web of guidelines perfectly into what he calls the 1-minute exam summary.
Okay.
If you want to remember the core formula of this entire complex framework, it is simply this equation. Risk equals WHO plus WAC plus BNP plus RV.
Risk equals WHO plus BNP plus RV. It really highlights that managing pulmonary hypertension isn't about guessing or just going by gut feeling.
Yeah.
It is a highly precise, dynamic balancing act. It's a constant negotiation between the patient's lived experience, like how they actually feel walking down a hallway, and the cold, hard chemistry and mechanics happening inside their chest.
It really is, and it raises an important question, though, if we connect this to the bigger picture of the future.
Oh.
Yeah, right now, this entire life-saving system relies on rigid episodic follow-ups. Every 3 to 6 months, the patient comes into the clinic, they walk the hallway, they get their blood drawn, they get an ultrasound.
Right.
But given the rapid evolution of 247 wearable health technology, smartwatches that can continuously measure oxygen saturation, or